I come to you this afternoon after a long day, which is very enlightening, as a patient advocate, a researcher, and a provider. Thank you for allowing me the opportunity to address the committee. My purpose is to direct the committee to an area of investigation that I have found productive. My name is Anthony Urbanek. I received my dental degree and master's degree in anatomy and cell biology from Indiana University and my medical degree from Vanderbilt while working toward a PhD in anatomy cell biology. In 1976, I was awarded a 2-year fellowship from the NIDCR, then known as the NIDR, for my self-directed study to induce reproducible temporomandibular joint craniofacial anomalies in an animal model by way of laser-induced intrauterine fetal surgery. After completing this study in my internship and residency in oral and maxillofacial surgery at Vanderbilt, I have spent the last 40 years in private practice in Nashville, having performed over 2,000 surgical procedures on the temporomandibular joint, half as open procedures and half as arthroscopic procedures with varying degrees of success and failure. I believe I am well qualified to comment on the current research, treatment modalities, and provider training for the amelioration of the symptoms of TMD. 10 years ago, after applying all my surgical skills and knowledge to the conundrum of TMD, and because of the less than predictable results, I decided that I could not, in good conscience, recommend surgery as the solution for the enigma. I had a burgeoning practice of patients, mostly females, showing up at my door requesting help, but I would now have to turn them away. Because of my broad background in the sciences and independent research, I decided instead to create my own study and ignore the myriad of congresses, textbooks, lectures, articles, and recommendations of colleagues from the many disciplines involved with the TMJ. I decided to instead apply the guiding light of my career. If one cannot find a solution to a problem, he is either asking the wrong questions or asking the wrong people, or both. So began a study by collecting data from the actual source with a very simple process. I began sitting with my patients and asking them and encouraging them to tell me everything they could about their symptoms, their history, and their problem with TMD. Many of them, at least half of the cohort, which was 12 out of 24, many of them repeated a similar comment. If I place a pencil eraser, my tongue, my finger between my front teeth and gently bite down, it feels better. After hearing this multiple times, the light bulb ignited, and I thought, I wonder what will happen if I make a device that fits between the front teeth and that it can be worn for 24/7. I constructed such a device and gave it to one of these patients who had symptoms for 20 years, asking her to keep it in her mouth 24/7, taking it out only to eat and return in 3 weeks. 3 weeks later, much to my surprise, she said her symptoms were all gone. Then I applied this strategy to another patient and another and another. Not everyone had 100% of their symptoms subside after 3 weeks, but everyone had substantial improvement and continued to improve over time to the point of wearing the device limited to nighttime only. After treating 30 or 40 patients in this manner, I knew the anterior occlusion, disoccluding the posterior teeth, was effective, but I had no idea how it worked. None. What were the anatomic, physiologic, pathologic, neurologic mechanisms at play that allowed a simple device that only occluded the anterior teeth and disoccluded the posterior teeth to have such a profound effect on relieving the symptoms of TMD in patients who had suffered symptoms for 10, 20, or 30 years? The next step consisted of what Albert Einstein euphemistically called thought experiments. For sake of brevity, I only have 5 minutes. I will give you the factual findings in bullet form. 1. Every TMJ patient I operated on had inflammation as the consistent common denominator in the first line of the pathology report of the mandatory tissue sample. In other words, the common denominator of all TMJ problems in my practice was inflammation. 2, 90% of the loads on the temporomandibular joint are from the posterior teeth. This fact has been validated by many, many dental studies. 3, and the centerpiece of my remarks and the understanding of the conundrum and the route to a most viable solution is this. Inflammation within the temporomandibular joint stimulates an autonomic response from the central nervous system to contract first the muscles of mastication, then the muscles of the neck, then the muscles of the shoulder girdle to hold the TMJ immobile in contradistinction to the constant mobility of the joint in normal function and bruxism. This mechanism, well known to our colleagues in the orthopedic literature, explains muscle trismus in tennis elbow, but is conspicuously absent from the dental literature relevant to trismus of the muscles of mastication in TMD. Conclusion. Unloading the temporomandibular joint in a defined manner to offset the continued and unavoidable loading of this joint will predictably alleviate inflammation within the joint and associated symptoms of TMD. Using this protocol, I have successfully treated over 2,000 patients in the past 6 years who continue to report amelioration of symptoms using the devices prescribed. Therefore, I respectfully recommend to this committee focus on evidence-based research and methods for unloading the temporomandibular joint while maintaining normal daily function as a superior way to treat symptoms of the TMD.
Thank you.
Thank you.